So that's why when you go into these different situations, that core belief is triggered, that people are judging you and criticizing you, and that's what's causing this anxiety that I would feel like literally be having a panic attack on the inside in terms of the degree of arousal in my nervous system, heart racing, sick in the stomach, flushed, unable to think clearly, unable to then speak, things like that.
Hi, I'm Jo Clark, and thanks so much for joining me today. This is the Redefining Midlife podcast, a podcast designed for the 40-plus woman who is determined to challenge society's myths and beliefs around midlife. It's for the woman who is inspired and ready to define midlife her way. Join me each week as I chat to health and wellness experts for up-to-date information on how to live well as some special conversations with incredible everyday women redefining what midlife can look like. Here's to making our next half of life even better than the first. Welcome to episode 118 of the Redefining Midlife podcast. Today, you'll hear from my friend and one of the most amazing women I know, Dr. Sasha Kowalenko. Now, if you're a long-time listener, you will have met Dr. Sasha way back in episode 11, which seems such a long time ago now. Now, we're going to be rounding out our series on neurodiversity with this powerful and heartfelt conversation, which will leave you with such a better understanding of neurodiversity and the impact that it has on women in the middle of life. Dr. Sasha is wearing a couple of hats today. Not only is she a highly experienced and highly qualified clinical psychologist, but she's also going to be sharing her own experiences as a woman who lives with neurodiversity. It's a conversation that opened my eyes and at one point left me in tears. That's the power of sharing our stories. Dr. Sasha also has very kindly shared some helpful links that you can find in the show notes. Now, this is truly a special episode, and if it could help someone you know, please share it with them. And if any of this information helped you in any way or touched your heart, I'd love for you to leave a rating and a review on the podcast app that you're listening to. It's going to help the podcast reach even more women. And together, we can support more women who live all around the world to live an incredible second half of life. So lovely to be able to welcome you back to the Redefining Midlife podcast, Dr. Sasha.
Thank you. What a privilege to be back. I'm so excited, Jo, for this conversation. Such an important one, I think.
Absolutely it is. And it's been a couple of years since you were on the show last, but I knew you were just a woman I wanted to come back to explain all about neurodivergence in general, but particularly as it works for women in the middle of life.
Yes.
So the topic of neurodivergence is being talked more and more, but I think it'd be fair to say the general population still may not have a great understanding of what that term actually means. Yeah. And we've already had 2 recent episodes on ADHD, and our lovely listeners learned that ADHD is a form of neurodivergence. But what other kinds of conditions fall under that umbrella?
Well, Jo, I wonder if it's, as I answer that question, to start off with just actually defining what neurodivergence is and maybe just giving a more simple term, because I think you're right. I think the term is used much more frequently these days, and a lot of people have knowledge of what that means, but there's probably just as many that don't. And so it might be helpful for your listeners and community to think about that. The term that I use when I'm talking about, I guess, in the context of neurodivergence, neuro meaning brain. And so what we're talking about is how your brain functions on a very foundational level. So we're talking about, the term I use is brain design. So how is your brain structured? How does it function simply by how you've been born? So we're talking about very foundational, like the foundations of our being that we have no control over, that environment can influence, but this is how we are born in terms of the structures of our brain. And that we know that, a sort of sizable portion of the population, our brains all work, and I'll describe what working means in a moment, in a fairly similar, or what can be described as typical manner, meaning, and it's the how it working bit is how we process information that comes into us on a sensory level. So what we hear, what we feel, what we taste, all of the senses, there's, I guess, descriptions around what that looks like in terms of a typical processing of information. And then we have some differences. So some people that will process information experience the world in slightly different ways. And that's really what we're talking about in terms of neurodivergence. It's those people or those people's brains that don't fit the typical profile of processing and experiencing of the world.
That's a great way to explain it.
And I thought it would be also, I was just sort of reflecting on the term neurodivergence as well. And it's interesting that my research indicates that it's a term that actually originated in Australia. So it's not surprising, isn't it? When we look at a lot of inventions or concepts, they often have their roots to the Australian scientists and researchers and thinkers.
Yes.
But so it was only in the sort of 1990s that this term emerged, and it was prior to that, and to some degree, there's still aspects of this, when people had brains that functioned in a different way, and this will come to your point about conditions in a moment, it was often seen as a disability. So to have a brain that didn't fit the normal profile was seen as a disability. So the work of, I believe her name was Judy Singer in the 1990s, started to question that and say, well, rather than thinking about it as a disability, but that it's a difference. And that's where this term neurodivergence arose from.
Gotcha. Okay.
And to answer your question, sorry, it's a long way to get to the answer to your question, is that now we consider, there's a number of different conditions. And when we say conditions, these are conditions that are defined by a book, a manual that psychologists, psychiatrists, some medical professionals reference, which is called the diagnostic, it's the DSM, it's our diagnostic manual that categorizes, and this is an important point I'll come back to a bit later, categorizes different types of psychiatric, mental, anything to do with the brain, mental health and wellbeing conditions. So in the category of neurodevelopmental conditions or disorders, we have things like autism spectrum disorder. We have ADHD, which you've covered off, in such a rich way over the last couple of episodes. We also have, learning differences, or some people would describe this as learning disorders, but I would say differences. So things like dyslexia, for example, would be something that people are familiar with. But through to other conditions, even like Tourette's disorder, which is, again, these are all conditions that have their basis, their roots, their foundations in how the brain works. Mm-hmm. So there's actually a broad spectrum of conditions that are associated with neurodivergence. My sense is, and I'd be interested to hear your perspective on this, is that when most people are using the term neurodivergence in the community, they're often referencing conditions like ADHD and autism particularly.
Correct.
I think it is being mindful that there are other things that are in the mix of technically that come under the umbrella of neurodivergence.
Yep. And I suppose too, Sasha, would be looking at what is the most common forms of a neurodivergence, and it would have been ADHD and on the autism spectrum as well. So that's probably why those two are thought of initially, but then not knowing, well, what else could be the conditions that fall under that umbrella?
Yes, yes. And I hope that makes sort of contextualizes in thinking about that concept of where people have, I guess it's often easier to get your head around, like with the notion of dyslexia. Okay, there's something that's going on in your or the person's brain that makes it difficult for them to learn in a traditional sense.
Yep.
And similarly with Tourette's, with the various motor and vocal impulse control challenges, it's not that they're intentionally trying to do anything. That's the way that their brain is formed and shaped, and that impacts the way that they are in the world, people with that diagnosis.
Yes.
ASD and ADHD is no different. It's in that spectrum.
It's just a much broader term. And I think we have to, rather than have the narrow focus of what we, might be used to, is just understanding that it is a much broader term. So what other sorts of things? So you mentioned Tourette's, you mentioned dyslexia. What other types, ASD, that we haven't really focused on?
Epilepsy is an example of a neurological condition as well. So again, I'm not saying that these are all similar, but they're all ones that relate to basic foundational brain functioning.
Yeah.
And that for all of these conditions, that they are there from, they might not be obvious, but that those structural differences are there from birth. Probably in utero, they're starting to form. So they're not conditions that are acquired through experience. And I think this is an important point for ADHD in particular. I know even in my training as a psychologist, which it was, my initial training about 20 odd years ago, there was still a lot of the clinical psychology population that didn't really believe in the condition of ADHD, that it was more of a children's behavioural challenges that mapped to that diagnosis were seen as a result of parenting or the environment. And the research is very, very clear that that is not the case. It's a structural, functional difference in the brain. And yes, that means certain things for our interaction with the environment. But I guess what I'm saying in simple terms is that these are conditions, these are experiences that are outside of our influence and the influence of our parents, our family, our teachers as well.
Yes. And so we learned in the previous episode that ADHD usually presents differently in women as it does to men, or the male-female differences. Is this also the case with other types of neurodivergence? And is that why it's so often overlooked or missed or misunderstood in women?
Yes.
Very simply, yes, it is.
Yes. Short answer is. However, I guess to just why I flagged earlier about this, the concept or the resource, which is the DSM, which we use in psychology practice, is so this is essentially a Bible, a core reference that describes for a range of different conditions, different criteria that basically make up that condition, whether that be major depression, schizophrenia, generalized anxiety, or autism spectrum disorder, or ADHD. In order to be diagnosed with any of those conditions, you need to have met the criteria that the DSM prescribes. Met the criteria, that means in terms of the symptom profile, but also what's really important, and I think it'll come maybe further in our conversation, is not just having experiencing certain symptoms, but those symptoms are at such a severity and intensity that they impact on functioning, is the sort of the two core components that make up diagnosis. Now, for the DSM, and that really is, there is one other sort of reference, but this is the core one that most people, particularly in most developed countries, would reference. Much of the research that has been used to form those diagnostic categories has come from, not surprisingly, from the male population. And again, I'm not saying that in a sarcastic or a inflammatory way. Like that is just the reality, and that relates, to a lot of healthcare, as I know you've talked about in previous episodes as well. So a lot of what we know about ADHD, autism in particular, has come from studies of those conditions or those presentations in males. So then when we look at the issue of the question that you asked about presentation in females, for a long time, pretty much for eternity, for as long as the DSM has existed, we haven't had, what we have had is a significant gender bias towards the male presentation. And as research has evolved and our ability to, like the tools that we have in terms of neurobiology and investigation of what's going on in the brain, is that we now know that ADHD, ASD in particular, look very different, or can look very different in women than they do to men. However, our DSM, our diagnostic profiles, they haven't caught up with that yet. They are, but they haven't actually caught up there. So And probably the core thing, and this is, again, I'm just speaking in generalizations across both ADHD and ASD, or autism spectrum disorder, is female presentations of those conditions, again, speaking very generally, are often, the symptoms are often more internally experienced, or the symptoms are managed internally by the woman. So they're not as obvious to people in general, even the woman themselves. And I'm a case in point in that with my own experience, but certainly to diagnostic clinicians or, psychologists, psychiatrists, GPs, all the things, but to the world in general. So it's that combination, and there's probably a third factor, but just to review, is our diagnostic criteria not capturing the presentations of women. And largely because in general terms, a lot of the symptom profiles for ASD and ADHD for women are not as obvious. They're not as externalized in terms of behavior. They're more what we experience internally.
Yeah.
And then the third important point that arises from that combination is, and it's a bit of a tangent, but it's one I always come back to and we've yarned about a lot, is then looking at the social, cultural, gender context for women, and how we've been conditioned and how we are socialized. Again, I'm not getting into sort of the rabbit warren of that conversation, but just to say, I think it would be fair to say that it's generally accepted now that although things are changing, particularly for women of midlife at this point in time, and all of our four women before us have generally been conditioned to be quite minimizing of our own experience, of our own needs, to not speak up or to compensate for experiences that we might make us feel uncomfortable or that we can't make sense of. I guess what I'm talking about there is a lot of what could be seen as good girl, people-pleasing, environmental influences that create those sorts of ways of being. This is a really important thing when it comes to thinking about neurodivergence in women, is that from a very young age, because we're actually neurobiologically, just generally in terms, there's some differences between men and women, is women we know have very sort of somewhat more advanced verbal reasoning and intellectual processing skills than men. So this is boys and girls. We know that there's clear differences there. So women are able to, or little girls are able, they pick up on these cues or what's right or what's wrong socially very early and determine whether they fit in or don't fit in. And if they determine, oh, I don't think I do fit what is expected or what other girls typically are doing or what other boys are doing, then they learn ways to compensate for that. Or the words that some of the audience may have heard is to mask or to camouflage. That is to cover up essentially what they have learned implicitly might not be the way for a young girl to behave or interact.
That's such an interesting concept, and that's something that Kirsten Bowles spoke about as well with her own explaining on how she navigated ADHD throughout her midlife, as well as what she's found clinically. And
Yes.
that's it. You see it in from my perspective of working with young children, you can see that so clearly. And that whole concept of fitting in is so damn important for children, because socially we're wired to fit in, not to be different.
Yes.
And it's interesting, isn't it, then, how as women we will have created ways to mask our true self, our true way of being in order to fit in.
Yes, exactly. Yes. And, I have my own lived experience through this as well. So I'm as I always do in my work, Jo, and this is thinking about things from a professional, clinical, psychology, whatever lens, from an evidence base. What is the research data? What do we know about this? And then what do I know of my experience of other people or women in particular in my practice? But I'm also a woman, and I'm also a woman in midlife. I'm also a woman with a number of kids with neurodivergent brains as well. And I think this is the case for many. I know I'm not alone, and many of your audience are in the same boat. So it's with all of those things coming together and then reflecting on my own experience as being a a woman and a human being, that I'm navigating all of this, I guess, experience around neurodivergence as well. And I'm going off on a bit of a tangent. We might come back to it, but I think what's often a trigger point for a lot of women in midlife is because thankfully our little ones, our own kids, or maybe even grandkids, because there is so much more awareness of neurodiversity in kids and the importance of early identification to be able to then give kids the right supports and tailor the environment to them rather than constantly forcing kids to tailor themselves, i.e. masking, to the environment. There's so much more awareness for young kids about that process that then that's also prompting, dare I say, older women in sort of the midlife and beyond to think about their own experience differently.
And do you think that in turn is leading to an increased willingness for women to go down the path of being formally identified?
Totally, yes. And it comes to the point, Jo, and this is again to come to my lived experience around this. I guess in terms of, if I just sort of zoom out a little bit about on this concept of diagnosis or labeling a condition or labeling a set of experiences as a condition or a diagnosis. And there can be, particularly within my own profession, a lot of criticism of that tendency, like, why do we even need to do that? For me, why we need to do that is it helps people make sense of their experience and to understand themselves. And when we're in this, I guess, realm of neurodivergence for women in midlife, what I know to be true for myself and so many women that in my personal life and in my professional life, is they've lived their life, their 40, 50, 60 odd and above years, maybe not actually really understanding themselves, or what they have internalized is certainly something for me, is feeling something's just not quite right. I just don't quite fit in. I just don't get things in the same way that other people have. This for me is a dialogue that I'm aware that I had from a very early age. And based on, I guess, clinical knowledge or research knowledge that was available up until, as I said, about 20 years ago when I was training, the way I had made sense of that difference that I felt was a consequence, and these things still stand. It's not as though that they're not in the picture, but there's other layers to the picture, was that I'd understood my, I guess, discomfort in certain social settings, my acute embarrassment, I would say, in certain settings where that I would then have a very strong physiological reaction, like very significant blushing all over my face and my whole body when I was put on the spot, when I had to introduce myself in any sort of circle, like at university or even in high school and then on into work, of feeling in other sort of social settings, feeling very anxious approaching those situations, and then when I was in them, even more uncomfortable. I had made sense of that in terms of my early life experiences. So I grew up moving around quite frequently in my early years of development. So I was having to transition into new schools, into new social environments. So I knew that I had that sort of environmental nature layer to my life. And I'd also always thought of myself and my parents' description of me was quite a very quiet child, very, I wouldn't have necessarily said shy, but just happy to do my own thing, very easily managed, for want of a better word. I didn't cause any, I would be happy, very self-sufficient child, very capable, sort of intellectually and academically. So just sort of fitted in that regard. So when I've then had these challenges that started to emerge that I became really aware of in my teenage years, of feeling really uncomfortable in certain scenarios, as I got through my training and my own therapy, what I had been taught at that time was, okay, Sasha, what you're most likely experiencing, you certainly meet diagnostic criteria, is for social anxiety disorder. So that is, you have a disorder that you are different to others in how you feel in social settings. But the root from the theoretical frame that was popular and still is, it still stands, was that you have a fundamental fear of being negatively evaluated by others. So that's why when you go into these different situations, that core belief is triggered, that people are judging you and criticizing you, and that's what's causing this anxiety that I would feel like literally be having a panic attack on the inside in terms of the degree of arousal in my nervous system, heart racing, sick in the stomach, flushed, unable to think clearly, unable to then speak, things like that, or speak minimally. So that had been the conceptualization that I'd had of myself for much of my adult life. And the consequence of that for me was working really hard to try and defeat that anxiety condition. We're going to, and this probably stood me in good stead. It meant that with that conceptualization, what I knew to be true as a psychologist is the gold standard treatment for an anxiety condition is exposure therapy. So that is you don't run away from those things that you find anxiety provoking. You stand up to them, and the more that you do them, the more you will challenge those thoughts, and your body and your brain will then learn it's not scary, keeping on going. So I've done that my whole life. I have, thankfully, because I've got other protective factors, and being a psychologist being one of them, I've had that mindset as I approach situations, the most innocuous situations for other people, like picking my kids up from kindy and having to talk with people at the drop-off zone. That would be something that for me still does, fills me with a reaction. I feel it now as I talk about it, that uncomfortableness in my stomach. Again, I can see your nonverbals going, wow, that's quite interesting. I don't think everybody has that same sort of reaction. So I lost my train of thought where I was going for that a little bit. But that's how I had conceptualized my experience, and therefore keep trying, Sasha, keep pushing, keep putting yourself in these situations. Eventually it will get easier.
And so have you found that then by putting yourself into those situations?
It's the interesting thing, and it comes to the neurodivergence and my experience of that, and where I land now is I'm 46 at the moment. And to be honest, Jo, no, those things have not become easy. As I said to you, I'll use the same example, pickups. I've got 4 kids, so I'm having to do almost 4 different interactions of that kind. I do still rehearse and think about what's going to happen. I still feel a sense of anxiety there. Whenever even doing things like this, I still feel a degree of uncomfortableness. And it's not, I'm just focusing on the social communication or social situations. I have other things, and this is what distinguishes autism is social communication challenges, and also then sensory sort of challenges that can show themselves in a variety of different ways. So there's certain environments and sensory inputs that I find challenging. So one of those is physical touch and affection of certain kinds, which in hindsight was really difficult sometimes in some phases of motherhood, that certain physical touches that were natural for my kids would give me a very strong reaction, a physical reaction, one of disgust, of, oh, I can't stand that sort of feeling. So again, 4 kids, that feeling didn't get any easier from the first to the second. So there's exposure there. There's how many years of early parenting and pregnancy. So then I hope I know I'm going, I hope this is all making
sense. Because I can imagine there'd be people out there listening going, that they might be somebody out there going, that's my experience as well. And that's why these conversations are so valuable. No,
I hope so. I know, because I know it to be true clinically, and then speaking to friends. So as I've gone through the process with my kids, again, my kids are, and it is important context, my eldest is 12, my youngest is 5, so they're still relatively young, and almost, I would say, at the cutting edge of the turning point in the research and the data around gender differences in neurodiversity. So as I've been looking at the world through their lens and then exploring their diagnoses, it's made me think about my own experience and how I had previously conceptualized and understood myself to say, oh, you know what? That's actually me. And I know that that's been a theme in the other conversations. So for me, this is more down the autistic spectrum pathway. I have some ADHD type features, but for me, the ASD profile is more prominent. And I do like to share that publicly because I think there is still a little bit of almost like a pecking order in terms of neurodivergent conditions that are accepted and more, are more accepted to have. And
Gotcha. That in itself is interesting to me.
Yes.
Where's that come from?
Yes. Well, I think it comes to the stereotypes. And for autism, it's the stereotypes. Well, actually, it's not even just a stereotype. It's one example of what it looks like to be an autistic or to have an autistic profile. And that why we now describe autistic spectrum disorder is to say there's a spectrum of behavior of presentations. And some individuals are at the higher end of the spectrum in terms of the impact that their brain design has on their ability to navigate a very neurotypical world. And at that end of the continuum, these are individuals, kids and adults that are nonverbal, that haven't been able to develop the skill of communicating verbally because of how their brain is designed and functions. And similarly, they will be very overwhelmed with the world. They will often engage in behaviours to help calm their poor little nervous systems that are so flooded with sensory input. So they will do things that are seen as stereotypical in terms of, say, flapping or rocking or headbanging, very sort of extreme behaviours. That picture at the far end of the continuum is what is seen as that is what an autistic person is. And what we've been conditioned to believe for a long time, again, up until very recently, is an autistic male. That is what we have as what an autistic person is. Whereas we now know that there is a very big spectrum from that end down to the other end, which is probably where I fit as a female, and many other females sit, which is I don't fit that profile. I don't look like that. So something that will often be said around autistic females is, and it has been said to me, particularly as a psychologist, there's no way you can be autistic. And this is from other people.
So it's gaslighting you that you couldn't.
Well, I would say it's not even gaslighting. It's more that it speaks to, it's the internal experience, understanding of your life. So these are from other clinicians that I work with in the pediatric space. So I'm also involved in assessing and diagnosing kids.
Gotcha.
With neurodevelopmental conditions or concerns. It is just that there's still so much to learn as practitioners, let alone as the general population. So if I can just anchor this back to myself and not in a sort of, egotistical way, but to say, so I know I don't look like what people perceive to be someone with features of autism. But what I've given you is examples of my experience of very enduring traits. These are things, as I said, that I have worked on with every possible intervention, very diligently, very in a focused way. That's the guts of being a psychologist in terms of knowing the ins and outs of these therapies, engaging in therapies and all of the self-development work. And those characteristics have not shifted. That I still I guess what's made it, and this is for a lot of women, I want to say this for a lot, I suspect it's a lot of women in your audience, because the other part of my brain, no, not the other part, but what also may make me vulnerable to having some of these autistic tendencies also makes me have an incredibly, what are the words I'm looking for? Sophisticated brain for processing information, a hypersensitivity around certain things and understanding. So I've been able to leverage essentially my intellectual ability to compensate for what I didn't know intuitively, which is what most neurotypical people will do socially. They just get it. Like you said, we're social creatures. that formation is there, that it feels natural to do certain things in social situations. For me, that doesn't feel natural. Certain people, it feels more natural, but that's not atypical of someone with an ASD profile like myself. That's where I do my best work, one-to-one. I have friendships that have spanned the course of my life, a handful, and then some others that have, you included, Jo, that have added into that handful, that people that get me and understand me. But I know a lot of people don't, and I probably come across in some settings as maybe very aloof. The good old Australian saying of up myself, thinking that I'm better than others because maybe I don't participate. But what's beneath the surface of that is it's being driven by going, I'm really not quite sure what I'm meant to do here. Maybe in certain situations, like I've got a skill set that I now can use in certain situations, but then new things come up. I'm like, oh, I don't really know what to do here. Or what my instinct tells me to do might not be socially acceptable. So I'm better off just not saying anything.
So interesting as you're explaining all of this, Sash, because I can just see or imagine how it would be for a woman who hasn't got this understanding and that depth of knowledge that you do.
Yes.
That they're living with the day-to-day reality of what they have without knowing that it's okay.
Yes.
That's another important part.
Yes.
It's almost you're not broken.
Yes.
But you've got the understanding of all of the different things that, like, more tools in your toolkit than the average person would have with the very same things that you're talking about.
That's why I like to share it, Jo, because I do have all of that. I'm a clinical psychologist. I have a doctorate qualification. I did not know this about myself until a couple of years ago.
Wow.
I'd completely conceptualized myself in a completely different way that was aligned with my training and the research and knowledge up until that point that had been derived. So it's exactly to your point. I, with all of my knowledge and experience, didn't know this. So of course, no one else is meant to. But what I want to throw in is two really important points that make, I don't know if you asked me this question, but I feel like it was on our agenda, is around the diagnostic process or even diagnosis. But what makes it really hard for diagnosing conditions like ADHD and ASD in midlife or this, after many years of life experience is life experience. So what I mean by that, and there's some really sobering data that figures I'm going to give you in the audience, is we now know that women that meet diagnostic criteria for ASD, so have an ASD diagnosis, have staggeringly more vulnerability to being in intimate partner violent relationships. The rates of experiencing sexual violence are upwards of around 80 to 90% more than the general population of women. 60% are more likely to have experienced physical violence than neurotypical women in the autistic population. And there's a variety of different, I guess, hypotheses. This is still a work in progress in terms of understanding. One of the things is that because of the social challenges that people with autism face, is women might then have a limited social network. So there's less, I guess, objectivity in terms of the people around us calling out in relationships or things that they're seeing in relationship dynamics. We know that autistic women are less likely to meet their full potential in work, and then in career and then financially. So that then is a risk factor for domestic and family violence. And then there's something more sort of potentially foundational at play, which is in terms of our perception of appropriate behaviour, risky behaviour, or what's okay in terms of how you were treated by your partner, that you might tolerate or put up with things thinking, oh, well, it's sort of okay, or maybe, or rationalising, making sense of it in the context of your own self. So we then potentially have, well, not potentially, so that's for ASD. Then we also know for ADHD generally, as a result, again, of trying to cope with sometimes, just simply coping, but also more foundationally because of dopamine that's implied with ADHD, which I think your previous conversations have explored, is that we know this is across gender. It doesn't relate to particularly to men and women, but I think men are more likely that people with a diagnosis of ADHD are more vulnerable to substance misuse disorders. So using alcohol and using drugs in order to regulate and to manage some of that dopamine pathway as well, which then creates another pathway of risk. So for women that have lived 20, 30 years of life, they have likely been exposed, that there's an increasing likelihood that they've been exposed to trauma.
Yes.
And trauma has an impact on the brain, on the nervous system, on relationships and all the things. So for me as a psychologist, clinical psychologist, when I see women in this midlife period, it is about unpacking all of this. And the third part we're unpacking, so we're trying to understand what were they like before life got in the way? What has been their life experience and how has that impacted on their nervous system and how they respond to the environment and perceive the environment. And then so critically, Jo, for me, is the combination of things. What has that meant for the belief system that they have developed, the core belief system that they hold about themselves, the world, and others? So if I reference myself, the theme that I have, and I can see the origins from both a nature and a nurture perspective, is that I'm not like other people. I am different. I don't fit in. There's something almost defective about me. And I'm stressing that word defective because it's not difference that's sort of talked about today, like it's great to be different. It's different as in what you said earlier. I've never felt like I fit in. I never felt like, even with certain close groups and bigger groups of people that looked on the outside like I was accepted, I never felt like I was actually part of the group. There was something always different about me. So that has then created that core belief, and then it becomes almost so hard to tease out how much was there already and then how much has been developed through that belief system, that I then see interactions like when I go to the school pickup zone, I'm hypersensitive to signs that person thinks that she is different or they're not talking to me. So therefore that confirms what I believe about myself.
And that's it. Women have that anyway, a lot of us, but you've got that too, that volume button's pressed right up for you.
Yes. And the same happens for women that have a more predominantly ADHD profile as well, but in different ways.
Yeah.
Feeling like they're too much. So I've always felt like I'm not enough. I'm not social enough. I'm not communicative enough. I'm not friendly enough. I'm not over the top enough. Whereas a lot of women that are more traditionally ADHD profile will feel the opposite. I've always felt that I was too much. I was too much for people, too loud, too creative, too talkative.
Yeah.
Which makes me, it's probably one of the last key points I do want to stress, though, to you, Jo, that we know from looking at the research around kids, particularly recently, is there's often a lot of overlap between the ASD profile and the ADHD profile. So there's a lot of women that will meet both criteria. And I'm sort of one of them. I have features there, but I'm more predominantly in the ASD realm. And that's just by nature that we're talking about a lot of regions of the brain that are similar in terms of executive function, prefrontal cortex.
Gotcha.
So that could be a bit of a double whammy for a lot of people, but for women in general. So that's an important point to keep in mind. But I guess it's then to bring it back to midlife, and it's really hard. Women might not have even had any concept like myself that there was some sort of difference there, because we're smart and we've learned and we've practiced this skill set to be able to look like we are everybody else. But then we've had life experiences that might also account for some of that difference. And part of that life experience then structures our core belief system that then further filters the way that we see the world. So the diagnostic process for a midlife woman is potentially complicated. It doesn't mean it's not possible, because it's certainly possible, but it's about finding a person that can help you map all of these pieces with the purpose of, in my opinion, of understanding, so that you can get to the point, which is where the journey that I'm on, which is one of greater two things, self-acceptance and compassion. To say, yes, in a true sense, I am different. My brain does not work in the same way that the vast majority of other women's brains work. And that is okay. Yes, it brings certain challenges to my life, but it brings a certain other skill set and strengths that I would not want to have.
Yeah. It's so interesting, isn't it? When a lot of women, hasn't been an area that's been studied and really gone to in any depth. Now we're starting to get more and more people going, okay, there is a difference. So it'd be just interesting to know what the rates of incidence would be if we're looking down 20 years down the track, when we've got all the numbers, we've had more research and really more care taken into identifying people.
Well, I can give you one, and this is more the opposite of that, I looked in having a look a bit of some of the data in preparation for today. I'm just checking my notes so I got the right figure, because it's an enormous one. 80% of autistic females remain undiagnosed at 18 years of age at the moment. 80% was the figure that I located.
Wow.
So if we use that to zoom forward or to zoom back away, it's a significant number of the population of women.
Yes. And
then the other factor that, sorry, I said finally before, but the other final piece of this puzzle for us in midlife, which I know is the core of your work, is around the impact of hormonal change in the perimenopause and menopausal period.
Yeah.
And that too can be a tipping point for, I guess, circumstances that will lead to women being, that maybe not even intentionally exploring diagnosis, but it could be other, they're seeking help because they're experiencing depression, anxiety, burnout. And this is not burnout in like, I'm burnout of work or, the traditional things that we talk about for burnout, but neurodiversity or autistic, there is actually a term. It's not a diagnostic term, but a concept of autistic burnout for women, where they're burnt out from the masking, the camouflaging, the things.
Yeah.
Because of doing all of that for decades, but then they hit the wall that we all hit, for want of a better word, of hormonal changes in the peri and post period. That mean we just can't manage all the things all the time. And then we know, as you have talked about so much, of what happens just on a normal level to the brain in that period. So we've got people like myself that have got brains that are different already, and then there's another change to that brain. So women potentially, again, this is an emerging area of research, is looking at the different sort of profiles for neurodiverse women and how not just peri and menopause hits them, but even how their experience through their menstrual cycle in their menstruating years hit differently as well. So that some autistic women, or there's some data that suggests autistic women are more likely to present with premenstrual dysphoric disorder, which is really acute premenstrual symptoms. And again, it's because of that sort of, if you think about it, like their base level neurological functioning is challenged, and then they have the hormonal changes on top, which exacerbates a whole lot of emotional, behavioural, psychological experiences.
Yeah.
So it's often for women in midlife, they'll often be going, I just can't cope, or I'm just so overwhelmed, or I want to leave my relationship, or I'm done. And they might go and seek help for that. And it's through that process that we start to go, okay, let's try and make sense of why is that so? Is it simply hormonal? What's going on in your life now? What's gone on in your life so far? What were you like when you were a little person? And how do we make sense of all of that so that you can understand yourself and go, okay, this makes sense. It's not because I'm crazy. It's not because I'm a bad woman or person. It's not because I'm not working hard enough to manage all of this stuff. it's the understanding that's critical.
It's huge as you're going through and explaining it. And not only were you talking about the hormonal transition that women go through, it's all the other big life transitions that happen in this stage of life on top of everything else that's in existence.
Yes.
Yeah. Huge. So what sort of things, help you, or have you found useful for yourself or for, your clients that you work with?
I know I sound like a broken record on this one, Joe, probably on two things, but the first one is it's for me the understanding that has driven acceptance and therefore ability to be more compassionate with myself, to understand myself and to be more, I suppose compassionate is the word, or more kind on a real fundamental level with myself. So if I don't feel like doing something, I don't push myself as much as I would have. And, some people might have different ideas about that, whether that's appropriate or not, but I actually don't care because I know myself now.
Yeah.
I know what my limits are, and I can see them, again, through that complex understanding of myself, my neurobiology, as well as my life experience, to go, no, if this certain event that I've been invited to is really not serving me, my family, is not aligned with my values, I'm not doing it. And I'm going to sit with the discomfort that might create in other people or even in myself. So it's that acceptance and understanding of, again, what my capacity is, and greater awareness into tuning into my capacity and making decisions about what I do and I don't do. I think it's the ultimate sort of strategy I think it's for everybody, but particularly if you have certain vulnerabilities in being overwhelmed in certain social situations, in certain environmental situations, is it's okay to say that doesn't work for me and I'm not going to do it. Or it's if the thing that you want to do is really important, like, for example, showing up in this way, although it's not my natural state of being, or actually this is not too bad because it feels very one-to-one. It is one-to-one, even though it's one-to-many. I just focus on you. I do things that are uncomfortable for me, even in this dialogue, in sharing my story. There's a degree of vulnerability and dialogue that happens with that. That I do that because it's very much aligned with my values about having impact and living in an honest and authentic way by practicing what I preach. So does that make sense in terms of it? Just by knowing myself, I then select what I do and I don't do.
Yeah.
And when I push myself, to do things because they are for the greater good. And that is really, it's not important to everyone, but that is important to me. I know that that's my purpose in the world.
It's a form of self-empowerment, isn't it? And just you coming on today, I was getting teary just hearing you sharing all of that, because we know each other on a friendship level as well. Just how powerful this conversation is going to be for other women going forward. It's something that our stories are so important, and it's only through sharing our stories and our lived experience as well. And you're able to add, thankfully, all that clinical experience and understandings that you've got as well, because some women's lives are just going to be completely different after hearing this, and that's really powerful. So again, thank you. And how then for people who, may not affect them personally, maybe it does, but if they know somebody else, how can a loved one, a friend, somebody who would maybe a sibling, a colleague, how can they help somebody that they know is experiencing some of these issues? Well, not issues, that's the wrong word, or ways of being.
Yeah, ways of being is a great term. I think it's, that first part, it's about that, education, and some of that comes to the individual as well, in terms of the person that has been diagnosed or suspects that they might be, is in sharing and saying, because it is what we do know about neurodevelopmental conditions of all the kinds that I said earlier, is that within each diagnostic label, the profile is very diverse, or the word is heterogeneous. So it's then we don't all look the same. And we don't therefore experience things the same. What I find challenging compared to another one of my friends with a similar diagnosis is different. So it then does come to us as individuals to be able to communicate to those people that are close to us. These are the things that I find challenging. These are the things that I'm, if you need my help on this, I'm really good at that. but it is about communicating what your sensitivities are or what your strengths are to people around you. And then for the people around you to maybe do some research. And you know, there's so much out there, and I can share some links that you can share with the community to be able to resource yourself to understand if you don't identify with the non-typical sort of population.
Yeah.
But I think it's then, and you used the word gaslighting before, Jo, I think it's then when someone has shared with you, this is my experience, this is what I struggle with, this is how I see the world, being very mindful of how you respond to that and not gaslighting by saying things like, intentionally or otherwise, most of the time it's otherwise, it's not intentional. Oh, you can't be autistic because you're not doing X, Y, and Z, or because you're so good when you talk on a podcast, you seem so confident and competent in social communication. Oh, no, every other person's got ADHD these days. You know, you're just jumping on that bandwagon. It's cool to have a diagnosis. So it's just being mindful of those things that I'm sure most people say, not with any intention behind them to be invalidating, which is essentially what gaslighting is, invalidating of another person's experience. To be open and say, oh, okay, I hadn't seen that in you, or that is so interesting that you're sharing that with me. So just being open to saying, thank you for sharing your experience, not challenging it in that direct way, but maybe saying, oh, tell me more. Tell me, can you give me an example? And ask the other person, how can I best support you?
Yeah.
So an example of that within my own family system and my own relationships is, as I said, the physical touch one. I have a thing around certain hugs. It's not all physical touch. It's not all. I'm not like, it's just certain things. And my mum, we've talked about this. She knows that now when I've been able to say to her, that type of embrace or that type of contact, it's not that I don't like it. It makes me feel uncomfortable. So what I'm talking about is I get a physiological response, which doesn't feel good. So rather than I can have that conversation, rather than it look as like I'm rejecting, oh, don't touch me. I'm just using my mum as an example. She knows that about me. She goes, I know you don't like when I do this, so I do this instead, because we've talked about that.
Yeah.
So I think it's not what we want to hear. We want, like, tell me the exact formula. What do I do? There is no formula other than being curious, being kind, and saying, okay, how can I best support you? How can I best play to your strengths and support you when you're in challenging situations?
Yeah.
And trying not to just say, because you don't feel that or you don't see it that way, that it doesn't exist. It's not real for the other person.
Yeah. Yeah. That makes total sense. And thank you so much for explaining what we can do, like as a neurotypical person can do to help in a situation, on how we can look after others. And being kind, that's the number one. Always be kind.
I don't know, it's such a easy thing to say, but you really don't know. You can say we don't know what's going behind closed doors and that typical interpretation of that, but closed doors in terms of what we're talking about, brain design, mind design, you just don't know.
No, you don't. You don't. And I'm so glad that I decided to do this series of 3 episodes, because it brings in the human aspect to something that is talked about, we don't know a lot about, or may not consider ourselves being, I'll put myself in a neurotypical, in inverted commas, person, just how it affects other people. And I think we need to have these discussions. And simply those statistics that you shared before are staggering and horrifying. So this really needs to be something that we talk about on the podcast. And so thank you so much, Sasha, for coming on and sharing your experiences and your professional understandings of this, and to help us understand better I truly value you, and thank you.
Likewise, my friend, and thank you for giving space and time and such time in your series of podcasts around this, because I certainly believe, and I know to be true, I just said the same thing, didn't I? But that it is such an important area. And I just really want to stress, because for women in midlife, in this, of our age, in that span of sort of 40 to 60, whatever you want to say, is we have lived a life often feeling not good enough and not quite sure. So this helps to, I guess, recalibrate our understanding of ourselves, and that were the words that you use, so we can understand ourselves better and therefore live to our potential and have the impact that we want to have in the world. That's why I feel like this is such an important conversation. And I'm so glad that you've opened it up. So thank you for having me too.
You're welcome. Thanks, Sash.
Thanks so much for listening and sharing your time with me today. I'd love you to hit subscribe on Apple Podcast or your favorite podcast app to keep spreading these empowering messages. Please share this podcast with other incredible midlife women in your world. Join me again next week for another redefining midlife conversation. Thanks again for tuning in.